Hello, everybody. Welcome to the Early Career Webinar Series, Episode 2. Can everybody hear me okay? Okay. Hi, I'm Rahul. So this webinar series is going to be organized by the Early Career Committee at American Spinal Injury Association. And we are going to try to provide a bench-to-bedside landscape of spinal cord injury research and medicine through the eyes of early career professionals. So although this is being organized and presented by early career professionals, we would really encourage and request the senior researchers as well and the clinicians to show their interest and support and maybe nominate their junior colleagues for the future sessions. So during this recurring webinar series, each episode will focus on one broad topic of spinal cord injury or medicine. And we'll try to present a transnational view, probably, and with two presenters, probably one from the research side, either preclinical or clinical research, and one from a more clinical point of view. So the theme for today is bladder and bowel dysfunction after spinal cord injury. And beyond highlighting and sharing this recent work by the early career professionals in our field, the goal is also to identify and highlight these rising stars in our field, and also to create more of a networking opportunity for all of us to come together with the same mission that we share. So before I introduce our speakers today, I would just give you a couple of instructions for the audience. So please mute your mics if you haven't already. All the questions will be reserved till the end of the presentation of each speaker. And if your question is selected, we'll give you an opportunity to unmute your mic and ask it in person. Or if you are not willing to ask it directly, we can also read the question out for you. And if you're not willing to share the question here, you can always email the question to the Asia committee or email it to me. We can share the question with the speakers, and you can hopefully get your answers later. And the last point I would mention is that these videos are being recorded, and they will be made available on the Asia website in coming weeks. So without further ado, I would like to introduce our first speaker, Argy. Dr. Argy Stampas is an SCI medicine physician and researcher who completed his training in University of Pennsylvania, Johns Hopkins, and University of Texas at Houston McGovern Medical School. He is currently the Spinal Cord Injury Medicine Research Director at TIRR Memorial Hermann and an associate professor at the Department of PM&R at UT Health Houston. His research interests are in advancing treatments and mitigating the development of sequelae resulting from SCI, currently funded to explore feasible neuromodulation techniques to improve neurological bladder outcomes. And his topic for the presentation today is improving neurogenic bladder management in SCI, told by an old physician, not too old, and early career researcher. So take it away, Argy.
Okay, well, thank you for that introduction. Let's see, can you see the screen okay?
Yes.
Great. So again, thank you for having me. I think we should first start by letting me explain what I mean by an old physician / early career researcher, because I am not early career per se, right? But early career researcher, I am. So let's see. So we have to take a trip down my memory lane, right? And I was able to find some of my old headshots. So this is med school Argy, happy, carefree, excited about medicine, and then finding a great specialty, PM&R, physical medicine and rehab, all about health and wellness and improving quality of life and function. So that was great. And then residency happened. Those were kind of dark times. Still love the specialty, but residency is rough. And I found a calling in spinal cord injury. So I moved on. There was a bright side after the storm, right? Moved on to fellowship. In fellowship, I was involved with a group at Kennedy Krieger in Baltimore that does a lot of electric stimulation. So I really fell in love with electric stimulation for spinal cord injury purposes. And then when I took my first position, it was in my hometown in New York. And I took all that e-stim with me infused it into the inpatient program. So all my patients were getting electric stimulation as much as we could. Our patients were being discharged with eStim devices, and our outpatients were continuing, or they were supposed to continue using their eStim devices. But you know, the chore of ordering stool softeners and laxatives and compression stockings really lost its charm after a bit. But what continued to really excite me was the research end of spinal cord injury. Like, why were we doing the things that we were doing, and how can we improve them? And so I looked to shift my career from being a clinician to being a researcher. And I was given that opportunity at another institution. So I picked up and moved to the country of Texas. It's a state, but they think they're a country. At Tier Memorial Hermann and with UT Health, McGovern Med School. And I was able to have some time, protected time. The chair was very supportive of this endeavor. I also took the Master of Science in Clinical Research course that was offered for clinicians. And I completed that course in 2021. And because of that, I qualify for most funding organizations as an early career researcher. So that's kind of how we came to it. And I think there's something going on when this is like November when I didn't shave. It's a no shave November thing in the States. This beard was like way thicker. I don't know why it's not coming across on the photo. It was, you know, I heard people call it glorious. So I don't know why this photo doesn't do it justice. Well, anyway, as a clinician, we are good at identifying problems in our patients, right? And the biggest problem that I could find in my patients was the problem of neurogenic bladder. And as long as Kim Anderson has been surveying people who live with spinal cord injury, the priority has been improving neurogenic bowel, bladder, and autonomic dysfunction research. We know very little about neurogenic bladder. It's surprising how little we know about it, but we know some things, right? We know that 95% of people who have a suprasacral spinal cord injury develop pathologic reflexes like detrusor overactivity, DO, and or detrusor sphincter dyssynergia, DSD. And when you have these pathologic reflexes, 50% will develop serious urologic complications. And the way we manage neurogenic bladder kind of reflects how little we really know about it. So the status quo early in spinal cord injury, what we've identified is you can't void, right? No one can really pee after a spinal cord injury. And not only that, we have to safely empty the bladder because we have identified, which was a big breakthrough, that the pressures of the bladder can rise and cause irreversible kidney damage. So we figured that out by safely emptying the bladder using indwelling catheters and intermittent catheters. So that part of the bladder function, we have a good handle on. But then at some point, the storage function of the bladder becomes bad, right? And this is when we intervene because now we have incontinence. And that's when we start prescribing meds. Overactive bladder meds, or OAB, have side effects: dry mouth, sedation, constipation, and newer associations with dementia have been seen in elderly people. And this is really concerning considering our patients are on lifelong overactive bladder meds on higher doses than non-neurogenic bladder patients, and often are starting at a very early age. And then in general, in the overactive bladder population, the medication population, so everybody who's supposed to be taking overactive bladder meds, they're not taking them. They just don't like them. Only about 27% of people take these meds, and those who take them, only 27% continue taking them. So there are newer meds with fewer side effects, but they're expensive. And again, that's another barrier because in the States, spinal cord injury, many people with spinal cord injury are living below the poverty line. So a better solution is needed. And like I said, I was always reading up on spinal cord injury. I continue to do so, and especially when it comes to electric stimulation. And I came across tibial nerve stimulation. And this is something that's been around for a very long time. There's really nothing new about this. The history starts in Eastern medicine. If you were to get acupuncture for a bladder problem, it would be a needle in that first web space of your foot. And that is innervated by sensory branches of the tibial nerve. So they took that knowledge and they did some rat animal studies, and they finally developed tibial nerve stimulation, FDA approved, in its percutaneous form. So in the percutaneous form, a needle is driven into the ankle to stimulate the tibial nerve. It has the same efficacy as bladder meds, that's been shown, but it has drawbacks, right? Because otherwise, a lot more people would be using it. The biggest drawbacks are it's performed only in clinic. You need a trained professional to do this. It also has poor patient compliance. So not just in spinal cord injury, but in other populations that use PTNS, the compliance is poor. You have to go to these clinics 2 to 3 times a week for several months, and it could be lifelong treatment. So that's not really a feasible treatment strategy, especially in spinal cord injury where access to healthcare is such an issue. So there's no home version. And I was like, I can do this. I can definitely stimulate that nerve. It shouldn't be a problem. And there is some science to support it. So very, very briefly, the normal way the bladder provides sensory input is through A delta myelinated fibers. And that's over here on the left. I can't see my mouse. And I don't want to click. Well, okay. There is another pathway with these C fibers, right? And they're there in everybody. As they do normally in the body, they transmit noxious signals, inflammatory signals, painful fibers. So what they've shown in pathologic bladders, like overactive bladder and interstitial cystitis, is that the A delta afferents are not the primary sensory. It kind of goes to these C fibers. And what they've shown is that when they give noxious stimulation, like with cold saline, you get this reflexive motor efferent, right? That's what they do. It's just a quick loop, pain to motor efferent. And then they can block that motor efferent by blocking the signal, in this case, using capsaicin. So we think just how other E-stim neuromodulation devices work for pain management, that this is also happening with PTNS, right? Just at a different level. We don't know exactly how it's working, but we think it's somehow blocking these motor efferents from the C fibers. And so I was like, great, let's just make it transcutaneous tibial nerve stimulation, or TTNS, and let's make it happen. So I put together, this is like real stuff from my early grant experience. This is what we're starting with the PTNS. And I was like, well, what are we doing in spinal cord injury that's similar? Well, we're stimming people all the time in spinal cord injury rehabilitation. So we have FES bikes. They have surface electrodes and leads, and I could probably, manipulate this for both, biking and for bladder, right? And I also befriended a bioengineer who was very interested in pelvic floor musculature. And he had a whole bunch of EMGs and vaginal probes and anal probes. And I was like, yes, we're definitely going to use those for some objective measures to see what the heck's going on. And of course, I'm going to add urodynamic studies, because that is the gold standard for the function of the bladder. So this is going to be the grants, right? No. So one of the comments, I'm never going to forget this, because it was so, it was actually like a real comment, not like a lot of the comments that we read that are kind of sugar coated. It was like, do you really expect people to consent to this? And I was like, yeah, they're probably right. So Now, going back to this about me, if we focus in on this part of my career when I'm in the country of Texas, I didn't really dip my toe into research. I kind of went in guns blazing as a Texan would do. And I put that into the KL2, and of course it was rejected. And so then I was doing pilot trials, making things more feasible, more realistic. And I put in for another KL2, and yes, this too was rejected. And then in 2019, I finally got the K award. And then it just happened. I went from famine to feasting. In 2019, I ended up getting 3 additional grants. So I went from like 0 to 4 in 1 year. And it all kind of was based on the pilot trials. So I just want to talk about the pilot trials. The first one we did was testing the TTNS on people with acute spinal cord injury on the inpatient floors. They were roughly within 4 weeks of their injury. I think the average was closer to 2 weeks. We tested it on 19 people, and it was a randomized control trial. We did baseline urodynamics, and then we had TTNS and control, which was a sham group where we placed the electrodes on, turned it on, got toe flexion, and then turned it down, turned it off. And then we did post-trial urodynamics. And we basically were really surprised at what we saw because it was what we expected. So I was very surprised. What we saw was, shoot, I really want this mouse. Hold on. Okay. Okay. Can you see the slide with the mouse? Yeah. So what we expected is that everyone's bladder is going to get worse after spinal cord injury. And we actually saw this just within the around 16 days of the pre and post urodynamics. So in the control group, the counts of detrusor sphincter dyssynergia increased as well as in the TTNS group, but the rate at which the DSD increase was much higher in the control group. And then bladder capacity reduced in both groups, but again, it was way more it was more significant compared to the baseline in the control group, not so in the TTNS group. So that was great. That was very encouraging. It's like, okay, we're onto something here. Now let's see if people can use this at home. You know, this could be something we start while they're inpatient, and we can use it at home. So the next trial we did was recruiting patients from clinic. Basically, we recruited folks that were performing intermittent catheterization and were on overactive bladder meds. We would test the device in clinic. So that's part of the inclusion criteria, whether or not we can get to the nerve. And the way we could identify the nerve is by getting toe flexion. So if I was able to get toe flexion and they were interested, they were in the study. And they took it home. They took the eStim device, the electrodes. They took it home for 4 weeks. I could not afford pre and post urodynamics. So I was like, okay, if this takes off, if this looks good, the next study is going to have urodynamics. But I did use diaries and I did use surveys. And so we could see here the voiding diary, week after week, nothing really has changed, right? So their free cathing frequency, their cathing volumes, and their bladder accidents was about the same week after week. So it's kind of not that exciting. It didn't get better, but this is in the setting of at the same time we're reducing their bladder meds. And so you can see that we reduced it right away. So they used it for a week, and then at week 2, we went down on their bladder meds. We tried to keep going down until they couldn't tolerate it, or they were telling me that they were just having more incontinence. So you could see that by week 4, the dosage went up, but still compared to week 1, it is a significant reduction in milligrams of overactive bladder medication use. And so we published this in a journal, International Neurourology Journal. Oh, and in our pilot trial, we published it in Neuromodulation. If you wanted to kind of refer to those. We also did the quality of life scores that are related to incontinence, and those were stable, no change. And then we developed, and I was shocked that there isn't really a good survey about anticholinergic side effects. So we put one together based upon the complaints of our patients who take these meds. And we did find that the dry mouth and feeling sleepy tired significantly reduced, which makes sense because they're on a lower dose of overactive bladder meds. So we had these really good pilot trials. We put it all together and we submitted it for more grants and better grants that could be more definitive, right? Beyond a pilot trial. So this is where we're at. These are the active trials that I'm involved in right now. The first one's kind of the one that I call the big one, right? It's a acute spinal cord injury. So they're recruited within 6 weeks of spinal cord injury, and we follow them to their 1-year spinal cord injury anniversary. And we're basically randomizing, performing urodynamics. It's a 3-arm study, and we do 2 weeks of induction. So for 5 days a week, 30 minutes a day, they're doing the tibial nerve stimulation. And then they're discharged with the device and they're supposed to continue doing it at home, and we're logging everything. And then by 4 months, we're doing a urodynamic study. Those in the intervention group, we're actually testing the dose because the literature supports in other populations that once you do it for a while, you can actually reduce the frequency of using TTNS. So we're also testing whether or not we can do this in spinal cord injury as well, 2 times a week versus 5 times a week. And then we're recording a bunch of secondary outcome measures like the log of use, compliance, bladder meds, monthly surveys like the NBSS that's specific to neurogenic bowel validated, the iQual, twice monthly voiding diaries, and of course adverse events. And our primary outcome is what do their bladders look like at 1 year? Did we mitigate the development of a real morbid pathologic bladder compared to the controls? Then in the other study, the smaller one, it's a 3-month study, and this is in people who have spinal cord injury, who are performing intermittent cath, and that are already using overactive bladder meds. Similar to the acute one, except it's a 2-arm study. It's a 2-week induction of TTNS with baseline CMG, and the primary outcome is a 3-month CMG. But after 2 weeks of use, we start reducing their bladder meds. And hopefully we can get them to the point where their CMGs look identical, their surveys look identical, but they're on no bladder meds. So we're basically replacing their bladder meds for this 30-minute electric stimulation. And what's really exciting is that I was recently funded to add urine protein analysis to my big study. So I'm collecting urine at the time points of the urodynamics. And I'm looking at 17 proteins at once, which is novel in itself. I'm looking at it cross-sectionally. I'm looking at it longitudinally, which hasn't been done before. And then I'm also looking at it through latent profile analyses to see if we can identify a pattern, a cluster, or what does a good bladder look like compared to a morbid bladder look like. So there's a ton of opportunity here for prognostic measurements, for therapeutic treatments even, right? So there's good opportunity here. I'm really excited about that. So in summary, I think persistence is key. I think for any clinician who wants to delve into rehab, they have to be into research, they have to be persistent. But it's easy to say to be persistent, because what you really need is that internal support. You really need your boss, whoever that may be, to believe in your idea, to support it, to give you time to develop your research ideas so you're not probing and putting together these awful grants, and then help you find funds for pilot studies, because I haven't seen anybody do it. You can't do it without the time and some money to start something. So these are my references. There wasn't a ton. and that's it. So happy to take any questions.
Thank you, Argy. That was a really interesting talk, and we really look forward to seeing your results from your upcoming trials, and wish you all the best. And so if you have any questions, please share in the chat. I think we have one right now from Chaitanya Gopinath. Would you like to unmute yourself and ask the question?
Hi, Arzi. Thanks for the wonderful talk. So I've been wondering since, tibial nerve stimulation and the inhibition that you show rely on suprasacral centers within the pontine micturition center. So it's been reported that once you transect the cord in any animal model or even large animal models, it's impossible for the tibial nerve stimulation to work. This has been reported by the Pittsburgh group. So what do you think is happening in your clinical trials? How do you think this is working? Because pudendal nerve stimulation as an alternative is being suggested to replace these tibial nerve stimulation strategies simply because it's ineffective in spinal cord injured patients. So I want to know your opinion about this. Thank you.
Yeah, that's a really good question. So far from what I've seen, it has worked in complete spinal cord injury based upon my pilot data. And what I think is going on is that with a complete injury, you're basically losing a lot of that inhibition, right? That cortical inhibition. That might not be that important though, right? What might be important is blocking that reflex that I talked about, right? From the C fibers to that directly trigger these bladder motor efferents, right? So I think if we can block those reflexive contractions that are pathologic, right? It's not a noxious stimulus. It's the bladder filling. It's Valsalva. It's a cough. It's a sneeze. It's a laugh. It's bending at the waist. Whatever it is, the body's interpreting it as a noxious stimulus, and it's constantly triggering a contraction. So these contractions, I believe, are what is the main pathology that leads to all these morbid outcomes. So if we could stop these pathologic reflexes, we can prevent truly morbid neurogenic bladder.
Thank you, Argy. We have one more question. We'll take this as the last question from Antonios. What is the stimulation protocol implemented in terms of frequency, pulse duration, etc.?
This question always comes up, and I'm usually unprepared, but I am prepared. It's a frequency of 10 hertz, duration is 200 microseconds, and the current is submotor. So identify the placement by toe flexion, so I get to motor, and then I ramp it down to where I see the toe relax, and that's where we leave it for 30 minutes.
Thank you. So with that, we'd like to thank Argy. And now we move on to our next presenter for today, Dr. Justine Payne. Dr. Payne is a board certified neurologics clinical specialist through the American Physical Therapy Association, certified pelvic rehab practitioner through the Herman and Wallace Pelvic Rehab Institute, and a certified yoga teacher through Yoga Alliance. She received her doctorate in physical therapy at Columbia University and graduated in 2015. After working in both the private and public sectors, treating individuals with pelvic health issues or neurological complaints, she began the pelvic rehab program at Jackson Memorial Hospital in 2020. She is right now a clinical mentor and a core faculty member of the University of Miami Jackson Memorial Hospital. She's also a teaching assistant at the Herman and Wallace Pelvic Rehab Institute, and she collaborates with other pelvic health practitioners within the University of Miami and Jackson Memorial Hospital Network. So welcome, Justine. And the title of her talk is Rehab Interventions for Bowel and Bladder Dysfunction in SCI. So take it away, Justine. Thank you.
Sorry, I'm going to switch to sharing my screen.
Yes,
FYI, I definitely referenced Dr. Stamford in my talk, so thank you for practicing everything I just and for explaining it, because, oh my gosh, I actually did my dissertation for my doctorate on using eSTEM for helping to manage bladder after stroke. And that was how I originally got interested in kind of the crossover between pelvic health and neurologic injuries. And so it's so interesting how it's evolved, because even from that time, I was like, wow, I don't really understand how this works. And I think all these questions are very valid, because it can be a little tricky to understand how these things are functioning. So to preface all of this, I am a physical therapist first. I'm a clinician. I'm not a researcher. I have so much respect for those who dedicate the time, but you definitely need the time, you need the funds, and you need a lot of perseverance to do research. So I'm grateful for everyone who has contributed to the research to allow me to apply it to patients. I primarily work in more of a recovery model with my patients. So if you're looking for someone to give you a talk about different types of catheters or adaptive devices to use with people, I'm not your gal. We have OT, and a wonderful OT who does that on the clinical side here at Jackson, and our OTs with an inpatient rehab do that as well. I work more with individuals who have more of an incomplete injury, who have some sacral sparing, who have a little bit of sensation, maybe a little bit of volitional control over their sphincters. And so my model is a little bit different. And so that's the perspective that I'll be coming from today. So typically speaking, when we're talking about spinal cord injury, we're looking at people who have either a reflexive pelvis or an areflexive pelvis. It's a typical division, just broadly speaking. So I'm sure that all of us who work with spinal cord injury already know this, but just to review, the division is typically done about T12. Any lesion above T12 is going to be considered upper motor neuron, and you're going to have high tone. So that's going to be high tone detrusor, the inner lining of the bladder, high tone colon and high tone rectal walls, and high tone sphincters. Both the anal and the urethral sphincters will be high tone, typically speaking. To confirm this, I usually will do like a bulboanal reflex, not a fan favorite, but you can use it as a reflex in order to confirm the intact loop there. Or you could do the anal wink reflex, which I find a little bit harder to elicit. And those individuals can use reflex voiding techniques, typically taught as a compensatory mechanism. And then the areflexic pelvis, those are individuals typically below T12, again, kind of a gray area, but typically speaking below a T12 injury, they tend to have more of a low tone within the bladder, the rectum, the colon, and the sphincters. And again, you can look at the reflex loops to see if they're areflexic. And they typically have a lot more difficulty with those reflex avoiding techniques. So they tend to have some different techniques to empty their bowel and their bladder. So the way I tend to explain bladder function is I try to keep it as simple as humanly possible. But when we're talking about your typical loop within the CNS, I'm not crazy about any of the graphics I can find, so I just drew this one. So when the bladder starts to fill, typically speaking, the A delta fibers within the bladder, as Dr. Stampis was describing earlier, typically, unless you have IC, will start to give off a signal towards the sacral micturition center, which is about S2 through 4. Then that'll shoot up a signal through the lateral spinothalamic tract up to the midbrain to let it know, hey, we've got a full bladder down here. Once the midbrain relays that message to the frontal lobe decides whether or not it's a safe situation in which you can empty your bladder. So that meaning environmentally and socially appropriate, as the frontal lobe does wonderfully for most of us. And then once that frontal lobe gives the okay, it goes back through an excitatory loop through the midbrain, back into the brainstem or the pontine micturition center, down back through the spinal cord to that sacral micturition center again, and it then will excite the detrusor, that inner lining of the bladder. I have my pillow pals with me. So it will excite the inner lining of the bladder, start to squeeze the detrusor, and then these sphincters need to relax. Okay, so that's your typical loop for a person that's neurologically intact, just to give you some background, although I'm sure if you're attending this talk, you know most of this anyway. However, when there's damage to the CNS, we have a lot more nuance in that. So we have to work with that. This is from one of my favorite texts. It's a Fowler text from 2012, 2010. So we may be dealing with not a suprapontine, but within the spinal cord. Like I said, if we have more of an upper motor neuron injury or those above T12, you tend to have more of an overactive detrusor and an overactive sphincter. So the detrusor is really trying to get the urine out, but the sphincter is closed, and the detrusor tends to react at inappropriate times. And then you can have more of the lumbosacral, where you have an underactive detrusor and the sphincter is typical, or you can have any variance within that. So how can pelvic health PT help? Sometimes it can't, and I'm very blunt with my patients. Like I said, I see people typically with sacral sparing. I tend to have more success with those who have a reflex type pelvis. And I am very, very safety conscious because I'm just not a risk taker with this population. The risk of UTI, the risk of hydronephrosis, bowel impaction, it's just too high. So I love to use a recovery model where appropriate, but choosing patients can be a little tricky. And I'm a bit conservative when working with them, just to give you some background. Typically speaking, for your reflexic bladder, they're going to use clean intermittent catheterization Q4 of 6 hours, shouldn't exceed 500 milliliters. And for your areflexic, some of them are able to do CIC, but many use an indwelling catheter. And then there is some variation of bladder dysfunction within those sort of divisions at the T12. There's always going to be some exceptions to the rule. So that's kind of more of the populations that I work with that have a little bit of variation. So if I have someone, let's say that they have an incomplete spinal cord injury and they're able to sense their bladder filling, and maybe they simply have a little bit of weakness of their pelvic floor muscles. So they're able to sense their bladder filling. They are able to volitionally void when they would like to, but they have trouble maintaining that urine within the bladder. So I call that a storage dysfunction, or unable to store. Pelvic floor muscle training can be helpful. What's interesting is there was a study done by Elmelund in 2018 that looked at seeing if functional electric stimulation added to pelvic floor muscle training would give us any more oomph behind it, have any more efficacy. And actually what they found is the results were very similar. There was no clinical significance between the two groups. That being said, functional electric stimulation, I absolutely will use if a person, for instance, has what seems to be intact motor control, but simply terrible proprioception, right? Just like you would with any other muscle. If they seem to have some intact motor innervation, but the motor control is simply lacking, using that functional electric stimulation to teach them how to use their muscles can be really helpful. What's also very interesting is there was a study in 2019 that used electrical stimulation directly on the glands of the penis and the glands of the clitoris for individuals with incomplete spinal cord injuries, and specifically those who have a neurogenic detrusor overactivity, as in when that detrusor is just contracting way too much. And what they found is they actually were able to have significantly better continence for those individuals. Now the N was very small, and again, I feel terrible for researchers. They started out with like 40 people and ended up with 6, but those individuals did have promising results. So hopefully something more will come with it. To be honest with you though, when I read the details of the study, I don't know how on board many of my patients would be, because the way that they designed it is that you just continuously have the electrodes on the glands of your genitalia. And for those who have an intact sensation, the bladder filling, they would simply turn on the e-stim to give themselves an urge suppression. And those who didn't have bladder sensation, they would have it on continuously. And this is about 40 milliamps, which is not a small sensation. So again, wonderful research, wondering how clinically applicable it's going to be, because I've introduced this idea to a couple of patients and I have no takers at the moment, but that's okay. Continue to spread the word. We also sometimes will use biofeedback, again, to help people with that motor control. So let's say someone seems to have some good motor potential. They have some innervation left, some sacral sparing, but they just simply can't figure out how to use the muscle. The biofeedback device will simply tell them what their muscles are doing. So when they squeeze, the lights will go up on a simple little device. And there's actually a software you can use that gives you even a better visual so that you can see really what your pelvic floor is doing. This could be used for weakness of the pelvic floor to use it to strengthen. But honestly, I oftentimes use it, especially in these high tone individuals, to learn how to relax their sphincters. Because while we do have an internal sphincter, whether it's the urethral or the anal, we have an external sphincter for both of those as well, which is under volitional control. So if you can learn to relax that sphincter, you can enhance the emptying of the bowel and the bladder. I'm not going to go through bladder retraining. This is normally a 3-hour lecture, so I'm kind of flying through. So other techniques that I can use for people who have, again, some motor control, once they've learned how to use their pelvic floor muscles, they can use a urinary urge suppression technique. Doesn't work for everyone, but again, if I find that they do have a good motor control of their pelvic floor muscles, really in its simplest form, I have them squeeze their pelvic floor muscles, squeeze, relax, 5 times, fully contracting and fully relaxing each time. And then after that, they get some diaphragmatic breaths in there, because bowel and bladder are not only controlled by your somatic nervous system, right? There's a lot of autonomic influence. And so parasympathetic input is associated more with storage. Sympathetic input is associated more with voiding. Sorry, opposite. Sympathetic input is associated more with storage, parasympathetic a little more with emptying. But for whatever reason, we find that actually doing diaphragmatic breathing will help with some of that storage. I think the bladder is just a little bit of a conundrum, because even though that autonomic influence, they tend to find it in that sense. Everyone knows that right before an important meeting, like right for this one, or right before running a race, you go to the bathroom, which would seem to be sympathetic in my opinion. So that's the way they typically describe it in the literature, but it seems a little more nuanced, especially because we find that that parasympathetic input does help people to develop better bladder control. And I think anyone with sort of nervous bladder could speak to that as well, which is actually what I feel on clinic. And here we go. Dr. Sampas already did all of this for me. Thank you so much. So I drew a lot of this from so many different populations, because I typically give this talk as a broad neurologic populations talk. And so there's so much literature, and I'm so grateful for all these researchers who are giving us more and more and more. But there's research within the Parkinson's disease population, post-stroke, multiple sclerosis. There's Dr. Sampas there, acute SCI. Sorry, I didn't quote your chronic one, but the results were, as you said, a little inconclusive. So I wanted to make us look better, right? So, and then there is a little bit of research within sacral nerve stimulation, which is also transcutaneous, but that's a pediatric study, neurotypical. And honestly, I don't recommend this simply because it's inconvenient for the patient to put it on, right? Because a lot of people just don't have the dexterity or the ability to reach and place electrodes on the sacrum. So just because of an inconvenience factor, I typically don't recommend this one. That being said, if someone is very, very sensitive in terms of autonomic dysreflexia or has some sort of sensory loss within the tibial nerve stimulation, this can be an alternative. And then your typical stuff, you know, some of my most complex patients, I use the simplest treatments. I'm like, what are you drinking? Oh, you're drinking only coffee and no water in your day? Okay, we need to change that, right? So sometimes simple interventions can be the most effective. Making sure that they're not just simply consuming bladder irritants, and really, really, really big, screening for constipation, because those organs are so darn close. Like within the pelvis, more pillow pets, you have your rectum and your bladder right next to each other, you know? You got a little prostate down here if you're a male assigned at birth. You got your uterus and your cervix in there if you're a female assigned at birth, but really the pelvis is crowded. So if your rectum is always full, your bladder is going to act a lot more frequently, and really your bladder capacity goes down. It's just a space issue. So really and truly, if I have someone with urinary urgency, overflow incontinence, any of that kind of stuff, stress incontinence, I'm treating the constipation. So again, seems simple, but you'd be surprised. And how often. And then of course, I'm not a prescriber, but I do consider medication influence, medication timing, and all that good stuff. So moving on, if I have someone, this is a little bit more where I go with spinal cord injury. If I have someone who is able to sense their bladder is full, but they're unable to empty it, there are some voiding techniques, right? But again, I'm very conservative. So I say, that's wonderful. You can feel your bladder. I'm so glad that your spinal shock is over and you have all these emerging new tools and new skills. However, I request that people still straight cath after using these techniques for about a month, because I need to ensure that their PVRs are below 100 consistently. Again, their risk of hydronephrosis, the risk of UTIs is just too darn high. I'm very conservative, maybe a little too much, all good. And really, to cover my butt, I try to send them for a urodynamics test as well, just to make sure that I'm not missing anything and that we're keeping them safe. Love using these techniques, but safety is always my number one priority. So of course you can go through bladder retraining, which is a very conservative technique. I'm not going to go into detail of this. It's a very conservative technique. You can find all sorts of resources on it. More of what I go into is just talking to them about how are you posturing yourself on the toilet. If your pelvic floor is not relaxed, which is highly under autonomic control, you are not going to empty out your bladder and your sphincters. You really and truly need to have full relaxation, which is really difficult if you struggle with trunk control, right? So do they have an appropriate sitting device? Do they have a comfortable commode? Do they have a cushioned commode? Do they have lateral support? Do they feel as though they can control themselves in the toilet? Oftentimes just finding an appropriate sitting posture is enough to allow the sphincters to relax and the pelvic floor to relax, to allow the bladder to empty. Oftentimes I will have them do just diaphragmatic breathing on the toilet. And then there are some breathing techniques that can help the sphincters to open a little bit more, like a or shh sound, oftentimes can be helpful as well. This was a study done in individuals with multiple sclerosis, but I do have people trial this, applying vibration directly over the bladder. And the idea is to activate the detrusor and overcome some of that detrusor sphincteric dystenergia, which essentially is when, like I said, when that detrusor is contracting a ton, but the sphincters are staying closed. So then the introduction of the suprapubic vibration has been found to sort of regulate that a little bit. I'm not clear on the mechanism, but it seems to work within this population. So this was individuals with MS who had urinary retention, and they had significant improvement in post-void residual. And they use this Queen bladder stimulator, whatever. I just recommend a vibrating teething toy, because as Dr. Sampis said, unfortunately, most of my patients are running on a very low SES categorization. And so this is like $6 from Target, as opposed to the Queen's bladder stimulator, which is a lot more pricey. I will say that anecdotally, and I often let patients even borrow mine just to try it. Anecdotally, I've actually heard from patients that this bladder tapping is more effective than the vibration. So interesting, because this is way simpler. This was done in a study, I believe, with individuals with simply with general neurogenic bladder, not necessarily spinal cord injury. I have to double check with agents in 2017. But really all you do is just tap the bladder 7 to 8 times and then just stop and attempt to void. And again, it's just sitting nicely on the toilet, breathing deeply, maybe using some of the sounds, whatever. And then the idea is, or what they suggested is occurring, is that the external urethral sphincter should relax while the detrusor contraction continues. Whoever figured this out is fantastic, because I've used it with quite a few patients, and again, incomplete with sacral sparing injuries, and people have seen some success. So exciting stuff. There are some other provocation methods. I have not seen these to be as effective, but again, they will not work with people who do not have a reflex loop that's intact, right? So we're talking below T12. These are most likely not going to be effective, but there's something to try, okay? Sacral neuromodulation, I don't do that. Crease maneuver, I don't do it. It's actually not recommended for patients to do this. And talking with my OT partner as well, we really try to stray away from this. This is traditionally taught a lot to individuals who have more of that below T12 injury. Not a fan. Really pushing the organs down, really for my people assigned female at birth, they tend to have a lot more prolapse with this. Just not a fan. but I understand why some individuals prefer to use this instead of catheterization, but I don't promote it necessarily. And of course, considering the influence of medications again, these are ones that would promote more of avoiding dysfunction. So, and I highly, highly educate all my patients on the signs of a UTI, of course. So let me see where I am with time. Okay. So we're talking about bowel dysfunction after STI. Again, you're talking about, we're going to skip that because CNS controlled defecation is very poorly understood because the enteric nervous system is essentially its own beast. After STI, again, you have that reflexic versus areflexic bowel, very similar kind of deal, okay? There are compensatory methods that are used. You guys probably all know them. They can be super effective. And again, I am not downing any of these. These are just some things that I like to use in addition to it. Don't down the basics, right? People aren't taking in their fiber. People don't take in water. They're not active, right? And one of the biggest issues I see after spinal cord injury, especially for those with low abdominal tone, they're not active and they're not activating their abdominals, and they're not getting that colonic motility, which is already slowed. So really, really need to get them moving, get them with appropriate fiber, water intake, good sleep hygiene. And if they're extremely stressed out, they're going to have constipation. I'm here to tell you. So abdominal massage is really, really great. It can increase bowel frequency, increase colon transit time. It can decrease abdominal bloating and instances of fecal incontinence, which tend to occur with constipation. So that would be more of an overflow fecal incontinence. It can be a really nice intervention. I have them do it usually at night if they do their bowel program in the morning. Super gentle, slow, easy, getting some parasympathetic input, relax the bowel. Toileting posture, again, love me some Squatty Potty. I'm not paid by them. I wish I were, but they are a fantastic company. And it truly helps some of the pelvic floor muscles to relax to allow the stool to pass. Again, e-stim. I'm with Dr. Stampis. I'm a huge fan of e-stim. This is a study done for individuals with SCI. They used abdominal electric stimulation overnight and statistically significantly improved their total bowel care time, reduced by about half an hour. Think of how much time your patients spend on bowel care. It's a lot of time, 30 minutes count. And there was a study done with sacral nerve stimulation, but it was implanted. It did improve their colonic motility though. TENS at the posterior tibial nerve, as well as AcuPoint SP36. So it's a study not done in the SCI population, but it actually increased frequency of spontaneous defecation. So again, improving that colonic motility that's often lost. 83% of patients responded with 3 times more bowel movements per week. So definitely something I recommend to patients as well. Love the e-stim. And instead of doing a Valsalva or a Creed's maneuver, this is the type of defecatory breathing that they can use to try to evacuate their bowels, again, if they have that sensation to defecate. So you breathe in, get the belly nice and big, keep the belly big, and then breathe out. Super weird to do in front of 40 people, but that's how you would empty your bowels without using a Valsalva. So it works much better if an individual has some sparing of their abdominal muscles, of course, because you're essentially trying to use the upper abdominals to push out the stool below. And that's, again, there's a tibial nerve stimulation study. It found, this was not within SCI, but still super interesting, results in improvements in fecal incontinence episodes per week in neurotypical population. So, and improved bowel urge deferment time. So, again, done in a neurotypical population, but there's potential for application to our populations. Fecal urge suppression, same kind of deal as with the urinary urge suppression. External anal sphincter strengthening, very similar to what I described before. This would be if someone had simply a weak sphincter, but their rectum was able to sense the filling and was able to start the emptying, because I wouldn't want to do strengthening on someone that has a high tone sphincter already, right? Again, appropriate choice of patient is key. Rectal balloon catheter training has been proposed to use with this population, where you simply fill up a catheter inside of the rectum and have the person acclimate to that filling in order to defer those bowel accidents but this is going to be very dependent on, again, rectal sensation. If someone does not have sensation within their rectum, I'm not going to use this intervention. But it can be used if someone is experiencing fecal urgency and has rectal sensation. I can help them to retrain and decrease the sensitivity of the rectal walls. And again, teaching about signs of fecal impaction, because I am always very nervous about this occurring. Need my patients to know exactly what's going on. And then there was this great study in 2018 about how locomotor training improves bladder, bowel, and sexual outcomes in people with STI. So again, I'm a PT. I'm pelvic, but I do my PT thing too, because it really does help. And that's it. Sorry I flew through, but that's all I got.
Thank you, Justine. That was a really nice talk. Thank you for telling us all about your work. It was really interesting to see all the other aspects of clinical management other than what we usually see in research.
Yeah.
So I think we
And
have
like I
one.
say, unfortunately,
Yeah.
I have to be very discerning in my patient selection, right? So many of patients come in and they say, oh, I can feel when I need to defecate. But when I do an exam, they're really not feeling it. So I have to be the bearer of bad news a lot too, which is not fun. But, you know, I always tell them, you know, my utmost goal is your safety.
Yes.
Anything I can help you, anything I can give you to help you, I'll give you. But you need to be very safe.
Yeah,
so
that's true. Thank you. So we have one question right now. It's by Gino or Gino. Sorry if I'm pronouncing it wrong. Panza.
Okay.
Would you like to unmute yourself and ask this question?
Yes, please.
Okay.
I can just read the question.
So I'll ask the question. In these studies
Okay.
or in your clinical experience, are these participants screened or are treated for sleep disordered breathing?
No, but I love your question. I love where your head's at. I used to, when I did my residency at USC, I worked with a lot of OTs that worked on lifestyle redesigns, what it was called. And so they would be our go-tos for sleep hygiene. And I absolutely loved it because I'm telling you, specifically bowel function, I see improve enormously when people are undergoing sleep studies and sleep hygiene retraining. The other thing I find is that a lot of people with nocturia, and this is neurotypical people as well as people with neurogenic bowel and bladder, people with nocturia tend to not be, it tends to be driven by sleep dysfunction much more than a bladder dysfunction. It's very interesting. So individuals with sort of your sleep apnea or simply not achieving REM sleep for whatever reason, they tend to have more nocturia. Super interesting. So love the question. I try to refer people all the time. I try to get them in for sleep studies if I can, but they're not typically routinely screened, no.
Interesting. I don't see any other questions from the audience, so I'll ask my question. And this is, oh wait, there's one more question. Let's go with that first. Sorry for not knowing literature yet. This is by Mary Schmidt. But are you saying that after 10 sessions over 2 weeks of, I believe it's tibial nerve stimulation, that the effects continue over a long period of time noted by your study looking at outcomes a year later? No need to repeat the 10 session treatments again, or am I misunderstanding?
So the literature is pretty variable. Dr. Stampis, please chime in. It's pretty variable depending on the population, but my recommendation kind of across the board is at least 5 days a week, 30 minutes a day. And I tend to encourage them to do that for at least a month. And then we can try, as Dr. Stampis is looking into in the future, to wean off to more of like, 2 to 3 days a week and see if they still see the benefits. But we're not really sure, as he said in his talk, if that's going to be efficacious or not. So I definitely have them be a lot more consistent for the first month. And then I say, you know what, if you find it's efficacious, maybe we can try to wean off and go more to 2 or 3 times a week after that, but we're not really sure.
That's what I was
And
getting
that's
at,
what transcutaneous
about your study, because you were using a 1-year post outcome measure. So I was wondering what that implied, or if you were doing any measurement during that year to determine when it starts, the effectiveness starts weaning down.
Right. So we're doing surveys monthly, and then we're doing neurodynamics at 4 months and at 12 months. So we have all sorts of measures, and we're tracking their bladder meds, right? So even if the surveys are insensitive, but they start telling us about incontinence and start taking bladder meds, we have all those kind of measurements to see how it's lasting. But we are using it 2 weeks initially, followed by routine use at home. It's not a one and done treatment at this point.
Okay, that's what I was asking, actually. So when you say it's not, then they do at home treatment, how often, how much? Is that the weaning down into the protocol that you're trying to get to, about 2 or
Yeah.
3 times a week? Okay,
Exactly. Yeah. We're making them do it 5 times a week till their 4-month injury anniversary. And then
Okay.
at that point, some are going to be randomized to twice a week versus 5 times a week.
all right, great, thank you. That's exactly what I wanted to know. Thanks.
You're welcome.
Thank you. One last question. In the interest of time, this will be the last question. Is rectal balloon training reasonable to try in tenesmus in SCI with sacral sparing?
Is rectal balloon training what?
Reasonable
To try with tenesmus.
Yeah.
Reasonable, yes. I would go, so having, as a pelvic health therapist, when you go through these courses, you have to be the patient. And let me tell you, I've had to do rectal balloon training. It's very noxious. Not that a rectal exam is a walk in the park, but there's something about having something rubber. So if I were going to treat tenesmus, I would take a much more conservative approach. It's not out of the realm of possibility, but I would go first to myofascial release or some strain counter strain or some other manual techniques before I jump to rectal balloon training. But it is absolutely a possibility.
Okay, thank you. So with that, this concludes our episode for today. And thank you for both the speakers today. We would like to thank the organizers at American Spinal Injury Association for helping us with this seminar series. And to all of you to joining in and listening and sitting at all your time zones, wherever you are in. We saw there are people from all over the world right now listening to us. So that was amazing. Before I conclude, I would just like to remind that this is the last episode of the series for this year, 2021. We will be starting the action again in early 2022, hopefully in January. So please spread the word, tell your colleagues and friends, try to submit your proposal, especially if you're an early career researcher. If you're a senior researcher, try to find your junior colleagues. If you think they will fit in the categories mentioned on the ASIA website, please reach out if you have any questions. And thank you. Happy holidays.
Holidays.
Thank you.
I'm just answering a private question.